Okay, we are recording.
Yeah.
And let me see.
Two people just joined on the telephone. Would you care to identify yourselves?
My name is Chris Hill. This is my second phone-in recently.
Hi, Chris.
Hi, I phoned in 2 weeks ago.
I recognize the name. Well, welcome back.
Thank you.
Chris,
Somebody else on
John
the
Appler
telephone?
here, Jake. Yeah, John Appler, Jake.
Okay. How you doing, John?
Good, good.
Good. Glad to hear that.
Okay. So let's see. G, Jake, Hill.
Oh, that's right. It's Chris with a K, isn't it?
Yep.
That's correct, yeah.
Sorry about that, Rick. Thank you, Rick, for correcting me. It's a good thing Rick's in charge of this thing. He keeps us straight.
You got two more callers, Jake.
Oh, yeah, I see that.
Hello,
Hello.
Brian from Bartlett.
Hi, Brian.
Oh, Brian.
How are you guys?
Hello, Brian. How are you?
Good.
Good.
How are you guys?
Fine. Thank you. That Jake, that was your partner who did on that research interview that you did. Brian and his wife also did it.
Oh, okay. Did you get paid yet, Brian?
Oh yeah, I got paid pretty quickly actually.
Yeah, so did I. They wanted to send me do it with PayPal, and I said, I don't want to do that. Can you send me a check? So they did. Took a little bit longer, I guess.
Oh yeah, they said it was going to take a couple of weeks even with PayPal, and I got it like a few days later. I was shocked.
Okay, and
It was an interesting call. I think it went well.
Yeah, I thought so too. I've been on a couple similar ones that I think ask really stupid questions. That one I thought was pretty interesting. It went fast. And
I left my water in the kitchen.
I think she did it very well.
Yeah, I did too. Hey, Len.
Hello, Jake. How are you?
Good, sir. How about yourself?
Pretty good. Who's paying you? I tuned in late.
Oh, I signed up for an online interview, my wife and I, about prostate cancer.
Yes.
Rick hooked me up for it with it.
Yes, my wife, she didn't want to do it, so I couldn't do it.
My wife wasn't thrilled because they wanted to do it shortly. She doesn't get rid of her last daycare child until about 5:30, and they wanted to do it at 6, so she wanted to be able to relax a little bit, but
sure,
we managed.
What was the drug they were pushing?
Oh, no drugs. They don't tell you. They don't really tell you who they represent.
Oh, okay.
What was the thrust of their call?
I'm trying to remember now. Just asking, how do you feel about your treatment? Are you happy with it? They ask you what your treatment is. What's been done. Are you happy with the way your doctor, talks to you and relates to you? Is that pretty much? Is that what you got out of it too?
Yeah, they wanted the whole history and how the doctors were and what we did about certain situations and And then they seemed to be focused a little bit on the Lupron stuff, and so at one point I thought that maybe it had something to do with that, but I couldn't really tell.
Yeah, I couldn't either. I think they assume that when you're metastatic, they assume that you're on Lupron. And of course, I'm on Xtandi too. So, but I didn't get the opinion that they were pushing anything in any way. It was very objective, I thought.
Yeah,
it was very professional.
So why did they need your wife, Jake?
I don't know. They just decided they wanted to talk to both of us.
Huh.
I've been on them before where they want to interview you separately.
Yeah.
But this time they interviewed us together, which is kind of a little bit difficult because we had to both fit on the camera. Instead of doing it separately, we had to both fit in at the same time. But we managed.
I thought they wanted her because she's better looking than you are. No?
Well, yeah, they saw me after about 5 minutes and they said, can we get your wife in here, please?
That's usually what they do to me. Yeah.
Yeah, you got to do something about that, Rick. That's annoying.
We have one other caller on the telephone. Would you care to
Yeah, stay like that. Don't move. That's good.
Yeah, but how do I?
This is Sylvester. I'm on the phone also.
Hi, Sylvester. How you doing tonight?
Sylvester.
How are you doing tonight, sir?
I'm doing good, and I hope everybody else is doing well.
Yes.
Thank you.
Greetings. The bear is on the phone.
Hey, Bear. How you
Hi,
doing?
how are you? Hi.
Good to see you.
Well, you can't see me, but I'm here. Yeah.
Who's the bear?
Larry Burke is the bear.
Oh, okay.
Okay.
Evidently, you haven't had any emails from him. Otherwise,
Yeah, that's right. No animations.
I told Bear that I actually, Bear is his nickname. I told him that I have a nephew whose real name is Bear. His christened name is Bear.
Is bear? Wow.
Yes, sir. Yep.
B-E-A-R or B-A-R-E kind of bear.
B-E-A-R.
Okay. Yeah.
Well,
I'm
there's
asking-
that famous outdoorsman, Bear Grylls,
Yeah.
on TV.
Yeah.
Yeah.
I don't
He's
know
the
why,
only other-
it just seems like a weird name to go through with a kid.
Yes, I can well imagine.
Hey, Scott. How you doing tonight? Treff.
Yeah,
We can't hear you.
Can we hear you, Shrek?
I can hear his dog.
We see him fiddling. Give us a shout.
Rick, your microphone's a little bit low.
Yeah, I can barely hear you.
Okay, let me try this. Sometimes it's louder, sometimes it's softer. Is that any better? Can you hear me better?
Not much better.
Not much, no.
Still feels like you're about 10 feet away.
No, I'm not. I'm really close. I don't know why. I mean, it's showing up as it's like registering pretty good. No.
We'll make do.
Sorry. And
All right.
somebody else just arrived on the telephone.
That's my wife.
That's his better half.
Yeah. Certainly the better looking half. I don't know about the better half.
Oh,
What's your name, ma'am?
Janet.
Janet?
Yep.
J-A-N-E-T?
Yep.
Mrs. Bear.
Hi.
Mrs. Bear. Yep.
Mrs. Bear, yes. Mrs. Bear is it.
So Bear sounds a lot like Peter Kafka, no?
Yes.
I thought it was Peter at first.
now Peter called to apologize. he's on a flight back to Maui.
Yeah.
It was due to
Suffering.
3 o'clock. So,
Peter's on the move a lot these days.
yeah, he is. All right, let's get going here. Although I have to say that we've aggregated a lot of people over the last 10 minutes, so it's good that
Yeah.
we
I think we have all the names right now so far.
yeah. So here's who I see that's on the call. Jake Hannum, Chris Hill, John Appler, Jake Ruckman, Brian Heisey, Len Sierra, Dennis Correa, Larry and Janet Burke, Eric Bookbinder, Sylvester, Treff, and Paul Frieda. Did I miss anybody? Okay.
Good job.
Sounds like I've got everybody there. Yep. And Treff, can we hear you yet?
Is he barking?
Yeah, there's some noise going on that sounds very strange.
No.
Oh, it sounds like a printer.
It sounds like
Like
a
a-
squeaky daisy wheel printer.
Yeah, can you guys hear me?
Yeah, we hear you now, Trev.
That's much better.
Okay.
We can.
But there's a lot of background noise,
Getting a
Shreff.
background noise from you too, so maybe if you could just mute out until you're ready to, and then we'll.
Yeah, put your phone on mute or something because there's an awful lot of background noise.
So, but we'll come to you. Don't worry.
Yeah, I'm not sure if it's Trev. I can't tell who the noise was coming from. It doesn't show on the screen.
It was, I think, before, but anyway. All right, so we don't have anybody new. So let's run down who we do have and see who would like some time tonight. And if we have the time, I got a couple of things that I learned from this conference that I was at on Saturday that was a survivor conference for all types of cancer. And I've got a stack of literature on my desk here from some of the exhibitors who were there, and it was actually, I learned quite a bit and it was helpful. So Jake, did you ever get your results back?
Some of my results. Yeah, I got a PSA,
Okay, so
but I didn't get everything I asked for.
We'll start with.
And I do have a question also.
Okay, we can allow you to tell us about. We can certainly allow you to tell us about your results, and we can have you ask a question. Chris Hill, how about you?
I definitely have a question.
Okay. Eric, how about you?
Yeah, I got some updates.
Okay. John Appler, anything for you tonight, sir? Mr. Appler? Still with us?
Yeah, sorry, Rick. I apologize. Got some good test results back, my PSA, so I'm okay. I'm just here to listen and learn.
Okay, well, you can tell us, but you can just give us an update on your test results. We'll stop by you for that. Jay Krugman?
Okay.
How about you? Anything for you tonight?
No, nothing for me tonight, Rick. Thank you.
Okay. Brian Heisey, anything for you?
Nothing for me tonight, thank you.
Okay. Len, back in the freeze your ass weather of Connecticut. Is that true, Len?
Freeze your ass as well as an excellent description, Rick. There was snow on the ground this morning.
Oh my God. You better
Yeah.
make it 4 months in Florida next year, Len.
You bet. 4 months indeed.
Anything for
Len,
I do have. I'm in Danbury, Connecticut. It's about 50 miles north of New York City. So I just have one quick question for anybody who's had their blood drawn for NPCP.
Okay. Okay. Dennis, anything for you?
Yeah, just a quick update on a couple of scans.
You know that you saw we know you saw Dr. Singh on Friday, so I got the word. So
I kind of figured you guys would hook up, being he was in town. And
yeah,
you kind of have that window to the world and know that
yeah,
anything going on with cancer, you're
yeah.
there.
He has a really nice smile, and when I went up and introduced myself, he was beaming, and I was really pleased to meet him. Larry and Janet, together or separately, would you both like to speak? One of you like to speak? Do you have any questions?
I'm going to speak, but I'm sure she has something to say as well.
Okay. Okay, and I will say, Janet, that we fairly often we do have um, women on caregivers, and quite often they appear without their husbands because their husbands are too reticent to come on the call, but the women are very interested and usually pretty well informed as well, I will say.
Yeah.
Sylvester, anything for you?
No, not this evening. Thank you.
Paul, Frida, anything for you?
Nothing for me tonight, thanks.
Okay. And Shref, unmute and tell us if you'd like to talk about something. I think you do want to talk about something if we pull it out of you.
I sent you an email, Rick. You can take a look at it. And whether it's tonight or next week or whatever, it doesn't matter.
Well, I haven't looked at it yet, so it's your call. If you want to talk, you're more than welcome.
Well, we'll just see how the time goes.
Okay. Okay. All right. So let's kick off with if any new people do come on, and there are a couple that have threatened to do that, we'll try and fit them in when they come on. But right now, it just looks like it's a bunch of old friends. So, Jake, tell us a little bit about your test results, and you got a question.
Yeah. Um, well, they for some reason I couldn't get a blood result. They said they didn't find it as enough sample a month and a half ago. So, but I had one in March. I finally got the results. My PSA has remained the same at 0.7. So it had gone up from 0.5 to 0.7, but it stayed at 0.7 for 2 months. So I'm still happy.
Good.
News.
Yeah, I keep asking for a testosterone, and I asked for a lipid panel from my other doctor, and they have a new phlebotomist, and I'm gonna have to write it down and say, do this, do this, do this, do this. But that'll be for the next time. So anyway, I'm happy for the moment.
How about other markers like your ALK phos and your ALT, AST, and your glucose and all of those things?
My glucose is always. Hang on a second. Let me get it. I'll be right back.
Okay.
I should have known you're going to ask about that. My glucose is always a little bit high. It's not, it's pre-diabetic, they call it, even with the metformin.
Mm-hmm.
I think it was 108.
Mm-hmm.
When I take it at home, it's usually 100, 101. But when I go to the doctor, it's high.
Mm-hmm.
When I eat something, then it shoots up.
Mm-hmm.
Alkaline phosphatase, 67,
Now,
which I think is pretty good.
That's great.
Is that a constant number, or what's the range, Len, for the ALK phos?
Oh, I don't have it memorized, but I believe it goes up to the 120s, the upper limit.
Yeah,
so according within the range.
Yeah, according to LabCorp, the normal range is 39 to 117.
Okay. So and
it does fluctuate. It goes up, goes down a little bit, but it's usually in that 60 to 70 range.
Okay. So I mean, essentially everything's pretty stable, and that's how you've been for a good while, which is good, and you're managing pretty well on the enzalutamide. So if it ain't broke, don't fix
Well,
it, right?
huh?
If it ain't broke, don't fix it.
Well, exactly. I do have a lot of, or I do have some symptoms from, I think, from the enzalutamide. I'm kind of shaky sometimes. I have to be careful I don't lose my balance.
Mm-hmm.
You know, but
I
I know those are some of the symptoms that people can or have had when they took enzalutamide. So I don't worry about it too much.
I'm not even.
Like you said, I'm not gonna make a big deal out of it as long as my PSA is down.
I'm not even so sure that it's only enzalutamide. I think that androgen deprivation therapy can throw off your balance as well.
Right.
So, and the fact is, you've been on that for a long time. So I wouldn't necessarily nail the enzalutamide for that.
Well, and I mentioned the tremors. You know, my hands kind of shake sometimes, and I mentioned that to my regular doctor when I went to her the other day, and she said, "Well, probably just essential tremor, but it could be Parkinson's. Go to a neurologist." And I said, "Well, I'm going to wait a while to see if it gets better. I hate doctors. I don't want to go to another one yet."
So I actually know. I know a little bit about essential tremors because my best friend has them, and it's a little scary because he's a surgeon. And what's interesting is that when he operates, he doesn't have the tremors. But for example, if he's drinking coffee, he does, or anything else, he has to use two hands. It's hereditary. His parents, his mother, I think, had it, and his youngest, his son, who's 24 or 25, has got signs of it as well. So the essential tremors, I don't know what you can do about them. I've actually asked Mark a few times about treatment, and I'm not sure.
Rick, this is Eric.
Yes.
I've got a tremor, and it runs through my family.
Right.
And there is no treatment for it.
That's right.
The treatments that they do are essentially the same as they do for Parkinson's. If it gets real bad, they can put the implant in. But the main difference between Parkinson's and essential tremor is they call it an intentional tremor. That is, you only shake when you try to do something. If you're at rest, you're not shaking. So that's the difference. Parkinson's, you shake all the
time. And that's what my doctor thinks I have, is because, like, if I go to reach for something, or I grab like before I go to bed, I'll take a swig of antifreeze, and I see in the mirror that the bottle is shaking a little bit, or I get my coffee cup and it's shaking. So she thinks it's just essential tremor, and like you said, there's not a whole lot of things they can do. She said possibly a beta blocker, but I'm already on a beta blocker, so
yeah,
I'm not going to worry about it.
Can I go to my call? Go ahead.
Go ahead. I'm sorry, Eric. Go ahead.
I was just going to say my granny had it, and when she would serve you a cup of coffee, by the time it got to you, most of the coffee was in the saucer.
Oh, geez. No, I'm not that bad, and I haven't given up my coffee, and I don't plan to. But and it's not in my case, as far as I know, nobody else in my family has it, neither Parkinson's nor essential tremor. So.
Yeah, that's unusual, but it can appear that way.
Yeah.
Yeah, I have it. My granny had it. My aunt had it. My sisters have it, and my son has it.
Wow.
Oh, okay. Well, they do say that enzalutamide can cause it too. I'm sorry, Rick.
I often wonder about, when because although Mark's sort of retiring and he's given up his national health practice, he just sees patients privately. But when people come in to see him and they see him drinking and his hands shaking like crazy, I wonder what sort of confidence it instills in your patients when you've got a surgeon who's shaking like that. But he's a very...
That would make me nervous, especially like an eye surgeon, for example, would be, It depends what kind of surgery he does.
He's a breast cancer and melanoma, so I guess he has a wide margin, but he's a highly respected surgeon. But you have a question. Tell us your question.
Yeah. Okay. I posted on Facebook. By the way, everybody checks our Facebook page 2 or 3 times a day, correct? Everybody say yes. Yes, say yes. Anyway, you should, because we try to keep up with the schedules and everything. But I posted an interview with Alicia Morgans and a doctor that one of the doctors that conducted the Prosper trial, which was using enzalutamide in non-metastatic castrate-resistant prostate cancer. And my question is, when you find out you're castrate resistant, that means they're trying to eliminate your testosterone, which usually means hormone therapy. Usually they don't give hormone therapy unless you have metastases. So I'm just wondering, why would somebody on it's not metastatic, why would they be on hormone therapy to even find out that they're eventually going to be castrate resistant?
Does
that make sense?
It does. I think I can explain it pretty quickly. And before I do that, I hope everybody on this call has liked us on Facebook. Not just gone to our site, but we need likes because it helps us. And for that matter, we need you to follow us on
YouTube.
Yeah, it's not follow. What do you call it? Favorite us or
subscribe?
Yeah.
Because we're very close. We're 91. We need to get over 100, and then I don't know what happens. But Rob tells us it's really important for us to get over 100, and we're getting there. We're really close now. So subscribe and like and follow us because I tweet from time to time. I tweet stuff out. So that's just a social media plug. To answer Jake's question, Jake, anybody who's on Lupron is on hormone therapy.
Right.
So since most men who have recurrent or advanced prostate cancer, well before it's identified as metastatic, unless unfortunately they've been diagnosed with metastasis, they're all on hormone therapy. And even people who have locally advanced disease like I did can be on hormone therapy. So the fact that you are non-metastatic and on hormone therapy is not at all inconsistent.
Okay.
Does that explain?
Yes, it does. Thanks. It's I was just, I think in terms of my own personal situation, and I always think of, it was metastatic before I ever got on hormone therapy, and I was trying to figure out why they would even have people in that situation.
Okay, well, I think John Appler, who's on the call tonight, is, thank God there's no sign of metastasis, but John's on hormone therapy. Anyone else?
Yes, correct.
I'm just looking to see no one else. But and I did it for 28 months, and I wasn't metastatic, thank God. So and men who have recurrence are often put on hormone therapy very quickly, even though we don't necessarily see metastasis, either local or distant.
Okay. Well, thank you for that. Anyway, the Prosper trial, I'm not sure if it's completed yet or not, but I can't remember the doctor's name that Alicia spoke to, but enzalutamide definitely is advantageous,
right,
for people in the M0.
Right.
category.
Right. And I saw another very good video with her and a Swiss doctor, a woman who is putting together a conference next year, and I watched that video. She's really, I have to say, she's very good, Alicia Morgan. Very, very good. And
Was it about the Prosper trial? The Prosper trial?
I don't think so. Was the one that you posted with a blonde woman from St. Gallen?
No, no, it was a dark-haired woman.
Yeah.
She was from Italy, I believe, but she didn't seem like she had much of an accent.
Okay.
So, but no, she was a brunette.
All right. We're moving along. Unless anybody else has anything to say to Jake. Does anyone else have anything they'd like to say to Jake?
Well, not necessarily to Jake or Rick, but just a comment that Alan Adele made recently. I can't remember where, but he said, if you've become castrate resistant, you have metastases, even if they don't show up radiographically. I don't know. He said it with a lot of confidence, and I don't know where that confidence comes from, but it's probably right. Micrometastases, at least.
Right. Right.
This is Janet. Are there any data on how long it takes to become castrate resistant?
Yeah.
And do those data vary by stage of cancer when you first start hormonal treatment?
Well, I think there's a lot of data because many endpoints are measured in when you become castrate resistant, when they're trying to test certain drugs. So the answer is that you would have to look at the drug, and you would have to try or at the procedure, and I mean there's probably huge amounts of data. That's the sort of question you'd want to ask somebody like Mac Roach at UCSF, because he's the master of meta-analysis, and he could probably point you to some sort of meta study, and I'm sure there are. I can only talk to you from anecdotal experience, and I'm sure the other guys can. And by the way, it's a worthwhile and a very good question.
But I mean, in general, is it less than 12 months or never less than 18 months? Or
let me try and answer you, and then follow up. The first point is that prostate cancer is really heterogeneous. It is so different in each person, and we know that there are probably 200 or 300 strains. At one point they were saying 76, and then they said 160, and it changes. And the reason why it seems to get more and more is largely because of the Dream Team and the Dream Team West studies, and the studies like Ellie Van Allen's metastatic cancer project, prostate cancer project. And the reason they do them is because they're trying to see and identify different generic types of prostate cancer. Now, we know that as far as adenocarcinoma is concerned, which is prostate cancer that is driven by hormones, by testosterone, there's a lot of different, the slow growing, the fast growing. Some men make very little PSA, others make huge amounts. I've seen men who have gone diagnosed with metastasis, who have become hormone resistant within 2 months of diagnosis. And there are men like Jake who are still responding, well, not responding to Lupron alone, but still responding to second-line anti-androgens. But I mean, I know men that who have responded for 4 or 5 years or longer just on Lupron alone, and who are diagnosed metastatic. So, you know, it can be anywhere from probably 2 months to more than 10 years. There's no, it really depends on each man. I'm going to throw this open so people can talk about it themselves when I'm done. As far as, you know, non-metastatic, it's the same thing. I mean, if you're diagnosed non-metastatic, you're unlikely. I've never seen anybody become castrate resistant very, very quickly, like within 2 or 3 months. But I have seen guys become castrate resistant within, say, 18 months to 2 years, that they become castrate resistant. But other people last for a long time. So to answer your question, and again, this is just anecdotal from my own knowledge, there's a huge variation. Why don't I throw it open to some people that are on the call, and people can talk about their own experiences. And anybody want to respond?
Well, Rick, I agree with everything you've said, but I would add that in general, the higher your Gleason score, the more quickly you're likely to become castrate resistant. So if you're a 7, you're going to last longer or remain hormone sensitive longer than if you're an 8 or a 9 or a 10, especially.
Right,
But
I
I would
agree
agree
with
with everything. Yeah.
That's a good point.
Yeah, this is Jake. Me personally, you know, Rick used my name in vain, but I actually got about 3 years out of just Lupron before my PSA started going up again, and that's when we started trying different things. And I also want to say I agree with Len about what Alan Adele said. If your PSA is going up for no apparent reason, there's something going on somewhere, and that's got to be a concern. You know, that is probably a metastasis somewhere. What they call what they call a micrometastasis, something that can't even be seen yet, but is floating around your body somewhere.
Okay. Anyone else like to talk about their experiences?
Yeah, this is Dennis.
one comment.
Go ahead, Dennis.
Just
Go ahead.
again, castrate resistant. I think that's what happened after, let's see, 17 months after my chemo and the Lupron, when PSA started to go back up again, and it wasn't responding to Lupron anymore. And that was where I was defined as being castrate resistant. For me, my original Gleason was a 9, and so that's my situation. I can't say what anybody else is going to be, but that was about, I would say, 17 months I got.
And you were diagnosed metastatic, correct, Dennis?
Yes. Yes.
Right. Who else?
Well, I don't have enough experience, but I'm still not castrate resistant. I had a Gleason score of 4+4, and it's been 2 years on treatment of Lupron and then 2 years of a break. So I don't have enough experience to say when I'm going to become castrate resistant.
Fantastic. But and Chris, were you diagnosed metastatic or not? I forget.
Yeah, I had a 3-centimeter lesion on my pelvis. So the lesion wasn't far from, very far from the prostate, but it was far enough to be called stage 4.
Okay. So that's a situation of 4 years, including some intermittent therapy. Who else would like?
Yeah, 4 years, and now it's starting to accelerate. So I have to do something now. Yeah.
Right. Who else would like to contribute on that one, on this?
I think John Appler had a comment.
No, Dr. Roach commented one time. I was just going to say the inverse of this situation is also not true in the sense that if you have very low PSA, that doesn't mean you get a break on hormone therapy, because Dr. Roach points out just a lot of people don't throw off much PSA, as Rick mentioned. So.
Right.
Yep.
Okay. Well, in the interest.
And my question was too. I thought that was very interesting that if as soon as you become castrating resistant, the assumption is that you've metastasized. Isn't what's really happened there is that your cancer has learned to eat something besides testosterone? I'm curious why it necessarily means that you have metastasis when you become castration resistant. Is there any more insight on that as to why that's the case?
Well, I thought that the cancer cells themselves started to produce their own testosterone or a precursor to testosterone.
Yeah, I mean, Janet's fairly close. My understanding is that when you become castrate resistant, what happens is that the cancer is able to dig out the testosterone from proteins that are not necessarily testosterone. So cholesterol is the best example. So cholesterol is actually, I don't want to say testosterone based because I'm not a scientist and I don't have enough knowledge, but and Len may be able to correct me momentarily. But one of the bases for cholesterol, when it's broken down, is testosterone, and the cancer gets smart enough to figure out how to pull the testosterone out of the cholesterol and uses that to feed on. So it doesn't need testosterone per se anymore. It finds the testosterone in other ways. Does that answer your question, John?
Yes, and is that actually a mutation of the tumor itself, or just a normal metabolic learning process?
The latter, a normal metabolic learning process. In other words, the cancer doesn't necessarily need to have mutated at that point in time. It's just gotten smart.
Yeah. Thank you.
Len, do you want to comment?
I would just say that I think the general consensus among oncologists is that right from the get-go, particularly with the more aggressive cancers, Gleason 8, 9, and 10, there are some cancer cells that are hormone sensitive, and there are some that are hormone resistant right out of the gate. So what happens is you get a free ride with those cancer cells that are hormone sensitive for a while, but once you've knocked them out, then you've cleared the way for the hormone resistant cancer cells to proliferate through other mechanisms other than the androgen receptor, and that's what happens.
Interesting. That's why they're moving up treatment schedules now for Zytiga and other things for anybody with aggressive cancer, at least 8 or more. Is that kind of why the research is headed that direction?
I think so. Yeah.
Yeah, that's interesting.
They call it selection. By killing off the weak soldiers, you're left with the strong ones, and that's why sometimes after we come up against castration resistance, and you're resistant to just about everything, the disease will rapidly progress because the more resistant cancer cells are the only ones remaining.
Mm-hmm. Interesting.
And correct me if I'm wrong, but isn't that where this the bipolar testosterone treatment comes in, where it sensitizes those other cancer cells, or shocks those other cancer cells so that they are then susceptible to hormone therapy? Do I understand that correctly?
I think that's the theory, but I don't think anyone knows for sure. But that's the theory they're working with.
Right.
I think that's one of the reasons why we believe that the testosterone, the BAT works. Another is that that flooding the androgen receptors with testosterone restimulates them to become effective. Talking of which, we've got to check in. I'm putting a note on my thing. Well, I've got to check in with Thibaut. We haven't heard from Thibaut for a while, and I'm wondering how he's doing. You know, now he got the bone marrow transplant, and he started on the testosterone on the BAT, and we haven't heard from him since just about the time he started on the BAT. So I'll drop him a line and see how he's doing.
I'm friends with him on Facebook, and he posts occasional pictures. He seems like he's doing okay.
Great.
He's lost all his hair.
Right.
He's totally bald, but he seems like he's playing with the kids and everything. So apparently he feels okay.
Good. Oh, good. Okay.
Yeah.
Well, I'll send him a note. And you guys should try and meet up sometime. You're not too far apart, are you?
No, we're not. We're probably within 10 miles of each other.
Okay. Okay. So we're gonna to keep moving down. And Chris, what was your question?
Before you go
I'm
on, Rick,
anticipating having to get additional treatment after a 2-year, not quite a 2-year break, and so I'm wondering, should I ask my doctor to consult a tumor board, which he consulted when I first showed up at UCSF? And also, should I get a second opinion, or is this a straightforward case?
So I guess the first thing, and Jake, I know Tom's on. I saw. I think he fell asleep. Did you fall asleep, Tom? Yeah, he did. He's nodding. He says he did.
he's showing off his new haircut.
I can see. Oh my gosh, we can see. So Chris, again, we can't give you medical advice. We can help you navigate. Remind me again. I'm just going to my notes on you. Remind me again who you're seeing at UCSF.
I'm seeing Dr. Kim, and I had Dr. Chang on board, and that gave me some source of comfort to have 2 doctors, but Dr. Chang left.
Yes.
So I had radiation, brachytherapy, and low-dose radiation for a month, and I also had Lupron with Casodex to start off with for 2 years. And I'm just a little nervous not having other doctors for Dr. Kim to consult with, but I guess that's okay. Let's just put it this way. Is it unreasonable to get a second opinion on something like this, or is it just a slam dunk to just go forward with whatever he recommends?
Okay, so a couple of things. First of all, this is really within the bailiwick of your genitourinary medical oncologist, who's Dr. Kim anyway. So even if you had a radiation oncologist on board, they wouldn't be the right person to be talking to about your follow-up treatment. They may have an opinion, but that's not going to be, for me, that wouldn't be the person I would be asking for a second opinion. Secondly, as we mentioned to you before, I think personally Dr. Kim's outstanding, and I would be very comfortable if he were my doc. And given the situation that you did well on hormone therapy for a couple of years, you took yourself off, and it's really taken 2 years to come back, which is incredible, really. I mean, that's a huge amount of time, as Len will tell you. The first line of attack would probably be, most men, I think, would find that they find themselves back on the hormone therapy. I guess what complicates this at this point in time is that over the 2 years, there's a lot of new research. And the new research would suggest that for men like yourself, maybe we should be looking at more than just hormone therapy, androgen deprivation therapy, LHRH, that you may be a good candidate for either chemotherapy or second line anti-androgen. Now, as metastatic castrate resistant, I think that makes you a good candidate for this new drug, Erleada, or apalutamide, which has recently been approved for metastatic castrate-resistant men, which has a lower.
Well, I haven't been shown to be castrate resistant yet.
I'm sorry.
I don't believe.
I'm sorry.
Because I'm not currently
Chris,
on.
Sorry. Metastatic castrate-sensitive men. I'm sorry.
Yeah.
I misspoke. So I think that you'd be a good candidate for apalutamide, and I would want to be discussing that with Dr. Kim, because that's a new drug and it could be a very effective drug. I mean, I think the discussions are, should I go back on ADT? Should I go back on ADT alone? Or should I go back on ADT with either chemotherapy or second-line anti-androgen? And if a second-line anti-androgen, which is the best one to go for?
Okay. So pretty simple, clear choice there.
Well, it's not a simple, clear choice, because if you were to do something more than the ADT alone, there are a lot of choices as what you could do. You've got choices of three different approved second-line anti-androgens: Zytiga, Xtandi, or Erleada. That's abiraterone, enzalutamide, or apalutamide, and or chemotherapy, which most likely would be docetaxel. So it's not clear.
Okay.
What is clear is that these are all very good avenues to control the cancer. So that's a real comfort.
Yeah.
But the question as to which way to go, I don't know. And there may be trials available for somebody like yourself, which is something to talk to Kim about. But I don't think you can do much better than somebody like Juan Kim.
Okay, well, that's very reassuring. I'll bounce this off him and just see what he says.
Who else would like to speak to that? Len, how long were your holidays, or have your holidays been?
First one was 7 months, and this second one is now a little over a year. But I need to see my oncologist next week, and we'll find out if my PSA is progressing or not.
And Len, if you were to go back, if they were to say it's progressing, you should go back, what are your feelings about doing more than just ADT alone?
I would be definitely open to that. And it's a conversation I'd have to have with my oncologist, Dr. William O. at Mount Sinai, and get his take on it. But I'd certainly be open to combination therapy, something along with ADT. ADT ultimately is going to be a dead end for all of us. So, why not try blocking other pathways sooner rather than later?
Okay. Anyone else want to talk to Chris or add their thoughts?
Well, this is Janet. My only concern would be if you're taking so many drugs at once that the side effects might become a little overwhelming.
That would be that's an understatement, because even just with Lupron and Casodex is hard to manage. So I'm going to be preparing for side effects, that's for sure. But I'd also want maximum possible survival too. So it's a toss-up.
Anybody want to address that?
Well, hopefully the combination drugs that you use don't have the same side effects. Like the ADT drugs, the primary side effects are fatigue and possible osteoporosis. We all know what they are. But most of the other alternatives, the most serious side effects would be bone marrow suppression. So you don't want to be on a combination of two drugs, both of which are going to suppress your bone marrow, which basically means you're taking out your immune system.
Right.
Yeah.
That's understandable.
Yeah.
I also wondered if why not just go with the one that has the minimal side effects, just ADT, and wait till that is ineffective, and then add the second line androgen once that's ineffective. Just Lupron alone for a while, and although that would be up to the doctor, I'm sure.
Len, I mean,
that's what my doctor did with me. She started me off on Lupron. This is Jake. And like I said, I got about 3 years before she added bicalutamide. And then finally, when that stopped working, she added Xtandi. But I think you're right. It depends on the doctor,
Well, it also depends. Did you have metastasis when you started Lupron?
Yes.
Yes, I did. I had one, only one, but I did have one.
Because with extensive, they say that you really need to start Zytiga right away with the Lupron.
Yeah, but Janet, you have to take time into account here. Both Jake was diagnosed how many years ago? 2010, Jake?
With cancer in 2010, metastatic in 2012.
Okay, 2012, and Chris Hill was diagnosed back in 2014, and at that time that wasn't the protocol. We didn't have the results that we have today. This disease is moving so fast. I mean, if I look at the treatment options available now compared to when I was diagnosed in 2007, it's just a different ball game.
Yeah.
And so you're right. It's very interesting to me that we're looking at combination therapies up front when for the longest time, most of the GU medical oncologists from the centers of excellence did not favor more than using ADT initially. They would use ADT and then they would add Casodex, and then maybe they would add a 5-alpha reductive like casteride or finasteride, and the only people that were doing triple blockade were people like Snuffy Myers and guys in the marina, in Marina del Rey. Whereas now, these docs are looking at combination, and the reason they wouldn't do it was because they were worried it would morph the cancer too quickly. And I still have not gotten a good explanation of why they don't think that is still the case for men who are diagnosed metastatic. But I want to come back to Len, because Chris's question, why not just go back on ADT, is right. What Len is exactly what Len's dealing with. Len, what's your thought process there to help Chris when he meets with his doc pretty soon?
It's a tough question. There's no clear-cut answer. As you just mentioned, Rick, traditionally you had most oncologists thinking that to keep some powder dry, just use one drug at a time, and when it's not working anymore, go to the next drug. So I don't think anybody can make this an easy choice for Chris or for me or for any of us, whether or not we should go sequentially or concomitantly with more than one drug.
Right.
But
no one really knows.
I thought the Stampede trial, though, was pretty definitive about doing Lupron plus Zytiga together initially.
Well, here's the problem. If they had done, yes, if you use Zytiga up front, it's going to be more effective than Lupron alone, for sure. That's what it showed. But what I wish they had done is if they had an arm that you had Zytiga up front compared to Lupron alone, followed by Zytiga when Lupron is no longer working, that's what should have been compared,
right,
in my opinion.
Right. The problem with drawing conclusions from some of these trials is you've got to be really, really specific that you're comparing apples to apples. Not that the trials don't give good indicators, because I always feel they do. But it's not exactly the same case, because those Stampede trials, as Len says, that was the initial treatment. And that's not Len's situation. So when you're talking about men, I mean, Larry's in a different situation in that he's just gotten diagnosed and he's trying to figure out which path to take right now. But remember that these guys are coming back to these drugs after holiday. Who knows? Going forward, we may find that people don't do holidays anymore. They may say, with all these drugs, we don't think you should even do a holiday anymore. Yet we know holidays work for some men. Look at Chris. He's gotten 4 years already out of Lupron and his 2-year holiday. And frankly, if a year and a half ago, his doctor would have said, "I'm just going to put you back on ADT." Probably wouldn't have even discussed anything else with him. But now, because of some of these other results, we're saying, well, should he do more than that? So we really have to be sure when we're depending or citing trials that we're comparing apples to apples, not to say that those trials aren't good indicators of what options are available to you. And that's why people like Chris and Len are wrestling with, what do I do next? And frankly, Chris may be 100%. He may be. I don't want to say 100% right, but there could be no reason to challenge a decision for him just to go back on ADT. But what I would say, Chris, is that if you've sought another opinion, then my feeling, if it were me, it would not be from a GU Med Onc at a center of excellence, because I don't think you're going to do much better than a Juan Kim. But if you went down to prostate oncology specialist, unfortunately Peter's not on the phone right now because that's where his GU Med Onc is, even though he still gets treated at UCSF. And he chose his GU MEDONC to be outside that system because he wanted the diversity of opinion. So if you were to go down to see Jeff Turner or Mark Schultz, you might get a completely different view to what Wong Kim is giving you.
But because things are so uncertain, who knows which is going to be right?
Well, here's where I think the difference is. I think that the doctors who are in the centers of excellence tend to treat very, very close to what the trials are suggesting. And the doctors who are independent GU MEDONCs, and there really aren't that many, especially since Snuffy isn't practicing anymore, they are more willing to use treatments that they see are having value, but outside of the parameters of where that trial or how that trial took place. So they're going to be more aggressive in how they treat you. And the criticism from the academic GU MEDONCs has always been, well, if you do that, you could accelerate the disease. And I think maybe that may have happened. But today, I'm not sure that that's so valid because we now are much more inclined to look at combination treatments. Anybody else want to comment on what I just said?
Rick, I'd just like to ask Chris, what's his Gleason?
It's a 4+4.
Plus 4, yeah.
Okay.
Well, I didn't even know there was such a thing as a 9 and a 10. I thought 4+4 was maximum.
No.
Yeah.
No, the Gleason.
You can always look to someone worse off. Like me.
Yeah, let me speak up. This is a Bear. I'm a 9.
Bear, just hold off a second. Let me explain something.
Okay.
I want to explain something to Chris. The Gleason scale goes up to 5.
10.
And typically, they will take the largest sample from the core and the second largest sample from the core. Occasionally, they'll quote a tertiary score, the third largest sample. And so that score is ranked from 1 to 5. Except what's ridiculous now is that we don't use 1 or 2 anymore. Very occasionally you'll see a 2, but most of the time a Gleason 3 is exactly, could be a 1, a 2, or a 3. And then there's a Gleason 4, which is more aggressive, and a Gleason 5, which is the most aggressive, which is pretty undifferentiated. So the cells all kind of mush into each other when you look at them. And what we do is we add those 2 scores. So you had two cores. One showed 4, and the second largest one showed 4. So you were a 4+4. I too was a 4+4. Now you can have a man who's a Gleason 9, for example, or a Gleason 7, and they could be a 3+4 or a 4+3, or a 4+5 or a 5+4. And that can be significantly different. And then you can have people, and we do see them. I don't know if we've got anybody on the call tonight, but we do have people that are Gleason 10s who are 5+5s. Does that explain it to you, Chris?
Yes, it does. I had a slightly different understanding. It was probably a misunderstanding, but that's helpful for you to explain it that way. I thought it had to do with how misshapen the cells were for one score and how fast they multiply for the other. But, I probably didn't write my notes down correctly.
You're not wrong. You're not wrong. How misshapen the cells are and how fast they multiply are features of each of the scores. So whether you're a 1, 2, 3, 4, or 5 will define the shape of the cell, and it'll define how fast that cell is thought to grow.
Okay, but I guess you clarified the fact that one of the numbers has to do with one sample and the other number has to do with the other sample. Exactly. So that's helpful.
Exactly. All right, Bear, I know you got something that you want to say. We really need to move on because we've got a bunch of people, and I will definitely come to you. I want to welcome people to the call. We have 2 new callers, both who came in on the telephone. Would you like to identify yourselves?
Jim Harrington, Rick.
Jim Harrington. Okay, God bless you.
No, thank you. Sorry, I'm a little late.
Jim. I'm so sorry I didn't get back to you. I meant to call you this weekend because I was thinking about you. And who else came in on the phone? Okay. So again, if you don't want to.
Ken Anderson's here also, Rick.
Sorry?
Ken Anderson also joined us, but there is somebody on the telephone.
Oh, Ken Anderson joined us, and Jim Harrington, and we have one other person on the phone. If you don't want to identify, that's just fine. Please listen in. You're welcome. Come back. If you feel like identifying later in the call, we'll give you another chance, and you can tell us. But just feel free to listen in. I'm just going to move along. John Appler, you had a question. Was that the one you asked me before, or it's something different?
No, Rick. I didn't have anything to say. I got some good ultrafine PSA tests back, and it came out to be less than 0.02.
Okay.
I guess that means it can't be identified. So I'm very happy and appreciative of the referrals I got from ANCAN to great doctors. Quite frankly.
Great. And John, how are you feeling?
Just like everybody says, and especially our mutual friend Peter, he said, 9 to 12 months into ADT, it starts to really hit you. And it's starting to hit a lot of ways, and so I'm right in the middle of that. But it's good to hear a lot of people going through the same thing. It puts it all in perspective. So I'm again grateful for this group, and we'll get through it. I appreciate your help.
And just keep up that exercise regime. I mean, what I found was that I would go. My job was to exercise every day, and I would go out and do it. And if it meant when I came back, I had to take a half hour or 45-minute nap, I did it. And I think that just kept me feeling good, or as good as I possibly could throughout. I just want to mention again.
Yeah.
Go ahead.
There's something came out in Medscape this week, another study also linked to exercise again, and there's supposed to be a huge study ongoing.
Right.
That's going to really definitively show this correlation. But I appreciate that. And I think everybody in the call should take that same advice. It seems, for some reason, people who exercise more seem to get through it better. So,
right.
Thank you.
I think the huge study.
Oh, one last thing I'll mention.
I'll come back.
Go ahead, Rick.
The huge study, I think, is the Movember study, which is now about, I think it's from 2000. They started it in 2015 or 2016. Go ahead.
Now, do they have any theories as to why that is? Why you do better because of the exercise, moving your blood around faster? What's the theories of why?
That's a great question, and I don't know. It would only be speculative on my part. Some of it I feel is that you're creating your own brain chemicals, and which just naturally make you feel better from exercise. They certainly help you strengthen your bones. I don't know why exercise helps you deal with fatigue, but it's now on my radar, and we'll see what we can find out about that. I'll ask some of my advisory board. So.
Yeah, one other brief update. As you know, I took a Foundation Medical Foundation 1 test, which looks at 600 genes, and I did find one mutation, which unfortunately has to do with cell adhesion, which means it makes it easier for a cancer to spread. But in talking to my GU medical oncologist, Dr. Agarwal, they might have retested to get more definitive results because they had a bad sample. He said, John, don't bother. Even if we knew all these things, there's just not enough conclusive studies to advise the treatment to you that hasn't been proven clinically. So getting back to your idea, Rick, that a lot of times, unless there are treatments out there for some of these gene mutations, but we don't know if they'll actually help you or not until the research is done. So
Right.
It makes you realize that the genetic testing is interesting, but it's still not really helpful to someone at some stages, as I am.
Right. I mean, I think it's I don't want to turn people off genetic testing because I think it's incredibly important. But what I also think is that to do it too early in the disease isn't helpful because there isn't enough evidence right now that early treatment is the right thing to do. It's like if you found out you were BRCA positive, would you and you were not you didn't have prostate cancer, would you have a prophylactic prostatectomy? Some people do. Sergey, what's his face, reputedly Sergey, what's his face from Google, he did, but I don't know. I mean, it's really incidentally, what was the gene you told me, but I never made a note of it? What was the gene that was mutated?
It was CTNNA1.
Okay, and that has to do with adhesion, you say?
Yes, it helps create an enzyme that actually makes the cells adhere more, a tumor adhere more, and without that, they tend to spread more easily. And unfortunately, that's one of the cases when, according to some of the research, that it is prognostic of where genomic testing. If they find that one result, it is prognostic that you could be more likely to metastasize. But there is some research out there that has ways of dealing with it too. It's just not clinically proven yet. So.
Okay. All right. Well, don't drive yourself nuts. I'm going to move on. Len, you had a question about MPCP samples.
Yes. Anyone on the call who's already given or taken their blood sample for the MPCP project? Jake, weren't you one?
Yes.
It's Eric. I have.
Okay.
I have as well.
Did you guys get vouchers for Quest Labs to take the blood, or how did that work? Did they charge you for the blood draw wherever you went?
I just got a tube, and I took it to my oncologist because she's the one that takes my blood regularly anyway, and I just asked her to take an extra tube.
Oh, okay. That's a good idea.
That's essentially what I did also. I just brought the kit in, and they were already familiar with the kit, and they just took care of the whole thing.
Oh, great. Thank you. That's it.
Go ahead.
This is Brian. I actually go to Quest normally to get my PSA test, so I took it there. When I was getting my PSA test, and the phlebotomist said, "Oh, I don't think we can do this." And then she went and talked to the supervisor, and of course the supervisor saw that it was something that they are familiar with, and so they went ahead and did it, and it was no charge to me.
Okay, thank you guys.
Okay. All right. So we hope you don't pay anything. If they try to charge you, you can send them to Jake. They try to charge you, have them call Jake, okay?
Okay, that sounds fair. Don't wait too long for the check.
Okay. I'm moving right along here. So then, Dennis. Tell us what happened when you saw Dr. Singh?
We had a good review. He has been reviewing all my blood work and so forth, and thought I was doing good. But he says because it's about 6 months now that I've been on the Zytiga that he recommended, and with the prednisone, the time for another set of scans. So I did that Monday, and went for a full bone scan and a CT of the chest, abdomen, and pelvic area. By the one previous to that I had, there was some issues where they saw something on one of my lungs, and in the report it just said, they couldn't confirm anything, but to follow up on it. So this is partly to follow up on that. But he said generally, you want to go about 6 months to get these scans in my situation.
Okay.
Yeah, it was good. The other thing I had from my other doc down here locally on my blood work was he looked at my globulin and total protein and saw that it was very low, and has requested that I do a they call it 24-hour urine collection. So I will be doing that the next time I'm scheduled for my blood work and drop that off.
Okay, let me come back to that. I just want to make sure that Ken Anderson heard the 6 month scanning criteria, because Ken, you and I have been talking about how often you should get scanned.
Yep, I heard it, Rick.
Good. Okay.
Could I ask if that's a bone density scan?
No, that's
Oh,
that's a bone scan. That's different from a bone density scan.
it's a whole body bone scan to look for metastases in the bone. But I did have the DEXA scan. The DEXA scan schedule, I believe, is on a 2-year.
Yeah.
I had one which was a baseline before I started my treatments of the chemo and Firmagon Lupron. And then I just had completed one here about a week ago, and that was a normal risk of bone fracture.
Oh, great. That's really good. And are you on a bone support?
No, I'm not on Zometa or the other one, Zofigo, I think it is. I've just been using calcium and D3, exercising, getting outside.
See, the only thing with that is that there are studies that suggest that the cancer spreads more slowly if it's in the bone and you're taking either Zofigo or Zometa, because the compounds make it more difficult for the cancer to spread. Bone is, my understanding from talking to an endocrinologist many years ago when I was on the Zometa, was that the bone becomes slicker. And so it's harder for the cancer cells to take a grip on the bone. So, there's reason to take those additional treatments, not only for bone strengthening. And, I think it's something that anybody who's metastatic should at least raise with their medical team as to whether they should be on, how often they're on. I mean, that's changed a lot. It seems that much lower doses are needed than what we thought in the past. And whether you go on Zometa or whether you go on Zofigo, that's also
Do you mean Zofigo or do you mean denosumab? Zofigo is radium-223.
sorry, I meant
Yeah, that was my problem.
There's Prolia.
yeah, no, not Prolia. It's not Prolia. It's stronger than Prolia. I meant Zofigo.
Denosumab.
So no,
Yeah, it's
Zofigo, XO, which is also denosumab. Okay, so Zofigo and denosumab are the same things, and they are, I think, the same compound as Prolia, except that No, wait a minute. They're not the same compound as
Xgeva
Xgeva.
is denosumab,
Thank you.
and
Zofigo is radium.
Zometa is the zotronic acid.
Thank
Right.
you.
And Zofigo is radium 223. That's something totally
Yes.
different. That's not a
Right,
bone
right.
strength.
I guess confused with the X.
Xgeva. Xgeva or Zometa. Too many X's. Xgeva or Zometa.
Yeah, one is an injection. The Xgeva is an injection every 4 weeks under the skin, and the Zometa is an IV every 4 weeks.
Correct.
Right.
Well, it's not every 4 weeks, or it shouldn't be. It was every 6 weeks. We now seem to think that it's manageable every 3 months.
Okay, maybe I've got some old data here. Yeah.
Right.
Yeah, Rick.
We've been reading
Hold
quite
on,
a bit
one
about.
person at a time. Ken, you go first, and then Janet.
I was just saying that Paul said every 3 months, because I was doing it every 30 days, and it was giving me joint pain. And he said, there's been proof that you're right, the lower dose is just as effective.
Right. Correct. Janet?
Yes, we've been doing a lot of research on this. A couple of things. Number one of our biggest concerns was the high 1 out of 100 incidence of osteonecrosis of the jaw that was considered a quote-unquote side effect of these bone treatments. And with additional research, we found out that the risk of osteonecrosis of the jaw, which is a horrible condition which may or may not be treatable, is much higher when you're getting these medications IV, and that the higher doses are also more of a risk factor, which are usually given to people who actually have bone cancer as opposed to metastasis to the bone. The physician that Larry is seeing said that these high doses, of injections every 6 weeks is not what he does, but he is going to give him a Prolia injection once every 6 months, which could be protective for osteoporosis.
Okay, so let me just address that, and then I want to go to Eric, because Eric has personal experience. We seem to think, even though there are people on this call who are getting it more often, we seem to think that once every 3 months is probably a decent dose. It also has a very long half-life. I have never seen the incidence of ONJ at 1%, but that I'm sure if that's what you found, it's probably right. I can only tell you from the experience on this call over since 2010, I can only recall 2 or 3 people having issues, one of whom was Eric. Isn't that right, Eric? Didn't you have dental issues from Zometa?
Yes, that's correct. Well, it was Xgeva, and I had a large piece of bone that died in my mouth. I lost 3 teeth.
Right. Again, it is a risk, but it's a fairly uncommon risk. If you're the one that
I'm sorry, this is Eric. If you were talking to me, I couldn't hear anything. There was a stupid motorcycle here.
Okay. What I was saying to Janet is it is a risk. It's not a very high risk, but if you're the one that it hurt, that it affects, it seems pretty high to you, as it did in your case. I did.
Very, very interesting.
But also this month, an advisory just came out from I don't know the site ABC Cancer or something, and they said that before starting any of these medications, one should go to a dentist, have a full mouth X-ray, be sure that there are no problems, be sure that your teeth are not going to need extractions or root canals, because the risk is much higher after invasive dental procedures. So standard of care is to have all your teeth and everything checked out before you start these medications.
Yeah, and that's always been the case, and we always tell people on this call, if you're going to go get it, if you're going to start it, go to the dentist before to make sure you don't need any.
Yeah, in fact, they say you should do the same before you start any kind of radiation as well, in the neck and the jaw area.
Yeah. I mean, probably, but we actually don't. Thank God we don't deal much with head neck radiation. But certainly, if you're going to go on a bone strengthener, just make sure that that you don't need any dental work before you start. So I need to keep moving along because we've still got a bunch of people to get around. Um, was there anything else, Dennis?
No, that's it.
Dennis?
No, not for me.
Okay, great.
Nope.
Eric, let me come to you, and then I'll go to Larry. With us, Eric? I hope that motorcycle didn't run you.
Yeah, I'm here. I'm here. Sorry.
I got worried. I thought that motorcycle might have run you over, man.
Yeah, no, I'm at the car place getting my car smog, so
okay.
I had to get that done.
Okay.
At any rate, I was just going to give a little update.
I'm having important question.
Oh.
Which?
Go ahead.
Is it that black car of yours that you're getting smog?
No, it's not.
Because I would have had a personal interest to know whether it passed or it didn't pass if it was that black car, Eric.
Yeah. Well, as it turns out, Rick, that black car is going on the market again.
Oh, okay. Okay.
I've got 4 cars, and I only need 1.
Okay. Okay, we'll talk about that later.
Yes.
So, go ahead.
Oh, I have a CT scan tomorrow and a bone scan on Thursday. I had my last, in quotes, chemo last Thursday. It affected me more than any other ones. I've been very sick from that. I was doing okay on all that before, but this hasn't done well. So at any rate, I will have those 2 scans, and then I'm going to see Dr. Agarwal, and we'll discuss what the next step will be.
Mm-hmm.
So that's my update.
So, so this was again the combination of carbo and docetaxel, correct?
No, carboplatin and paclitaxel.
Yeah, and Jeftana, sorry.
Jeftana, right. Right.
I'm slacking here today.
Yeah. It dehydrates me terribly. I had to go to an emergency room. We decided to take a trip to Calistoga, and I spent half the time in the emergency room.
Oh dear. And they gave you a couple of liters of fluids, and it brought you back to normal.
It didn't bring me back to normal, but it brought me to a much better spot.
Okay. Okay.
Yeah, I was having trouble with the blood pressure. I had blood pressure being 65 over 47.
Yeah. That was my next question. Was it evident in your blood pressure? And yes, it was.
Yes.
And where did you get scanned? UCSF or SADA?
No, I'm going to get both scans at Alpha Base. Okay. One at the cancer center and one at the hospital.
Is there equipment?
The bone scans at the hospital.
Is there?
Sorry?
Is there equipment as good as the UCSF equipment?
For these scans, it is.
Okay. Okay. And.
Hey, Rick.
Yes.
It's Jim. I just want to ask a question. How many chemo treatments did you have?
7.
And then it started getting worse at the very end. Is that what you're telling me? More side effects?
Yes. Yes.
Yeah. Well, I've had 18 docetaxel. It's still
wow.
Oh, for life.
No,
I don't get it, but I have to deal with it. I just wondered how many.
I was much sicker on the docetaxel. I was as sick as I got on this 7th round here.
Oh, well, that's
But
really heartening to hear.
From the very beginning of the docetaxel, I was that sick.
Yeah, I've heard this before. Yeah.
But but at the same time, I would also say that you've had these this dehydration and blood pressure issues.
Yes.
Tana too, right?
Yes, absolutely.
And
I had to have hydration. I just had an open order for hydration and went in anytime I needed.
Right, and to some extent, and then they diagnose you with Addison's, and that may have something to do with all of it. May have a lot to do with all of this.
Yeah, absolutely.
Right. So the game plan is to get the scans, and then to go see Agarwal. Have you had a PSA since the 28.5?
No, I have not.
All right.
I'll be getting that this week.
Okay. Well, not much else to discuss until you get to see Rahul. When are you going to see him?
Next Tuesday.
Okay. All right. Well, keep us posted, and check into that ES414 trial.
Yeah.
See what
absolutely.
Whether you're suitable for it or not. Okay. Larry, you're next. I just want to see we've got 2 people on the telephone. Anybody like to identify who's on the telephone?
Hey, Rick, one of them was, this is Brian, one of them was me. I accidentally disconnected. I came back.
Okay. Well, we'll put you back. I'm putting you back on.
Okay.
Okay. No problem. All right, let's keep moving here and go to the bear.
The bear. Let me give a shout out. Len, I was a guy that did a lot of water skiing on Candlewood Lake, which is in your neighborhood, yes? So I'm quite familiar with the area. And I want to give a shout out to Dennis. We had a great conversation yesterday, and I appreciate the time. To Chris Hill, just so you know, there is somebody that has a Gleason 9. Unfortunately, all 12 samples were positive. Half were 4 5s. And of course, we cleared that up, and the other half were 5 4s. And I don't want to say I'm proud to be the person to tell you this, but there is such a thing. Okay.
Sorry to hear, but yeah, now I know at least.
Yes, and they're still alive and still kicking. So I mean, so far so good. I had my second Lupron shot yesterday, and I'm one of these going to be multiple. So I am scheduled to go on Zytiga and prednisone, probably starting the next several days. And Janet was talking as well. I am having some dental cleaning and prep, all of that, to possibly go on Prolia. Now, the good news for me, because I had my first Lupron shot March 9th, I believe, or around that time. And to say, initially, my PSA was 18. My blood work came back yesterday that it's 0.17. So that was good for me, that I was responding. And the testosterone, which was in the 400s, and I don't know how the scale is now, is a 10. So it looks like just on Lupron alone, things are going in the right direction. I am scheduled to see Dr. George on Monday. Rick, I will certainly mention your name just to get a second opinion. But so far that it looks like I am responding to the Lupron alone, and hopefully even more so, and it'll affect my meds when it comes to the Zytiga and the prednisone.
That's excellent, Bear. Good, congratulations.
Thank you. Yes, that feels good. Very, very little good news. So that was certainly welcome yesterday for sure.
And
Yeah, by all means.
as you or Janet have probably already read, that when your testosterone and your PSA fall quickly, it's a good prognosis that you're responding and that you're likely to have longer success out of ADT alone. But again, as we said, ADT alone is no longer the standard of treatment for men diagnosed in your situation.
And I have to mention another thing. It sounds like something a child would mention, but um, I had been using a catheter now for a month,
right?
And I had not gone on my own, urinated on my own,
right?
Up until 3 or 4 days ago. So and this is just, of course, a theory. I believe that the Lupron and shrinking the prostate to an extent gave some relief to my urethra, and I am starting to output on my own even more than I am when I use a catheter. So that is also good news for me.
I probably, again, and you could talk to Dan George about this, but more likely what's happening is that the Lupron, the LHRH drug, is shrinking the tumors. And
Yes.
it's not so much that it's shrinking the prostate, but it's shrinking the tumors. So whatever the tumor was blocking, that blockage is reduced.
Understand? Yes.
Okay, that's great. That's a really good report. And when are you actually starting the Zytiga and the prednisone?
Well, the Zytiga is going to be delivered tomorrow, and I was thinking of putting it off for several weeks because I'm going out to Denver, Colorado. But my wife is insisting that I start it tomorrow, actually, and then if I have an adverse reaction, I still have, when I say time to recover, because I understand that if I find out, let's say I have an adverse reaction the first several days, if I stop, it should be out of my system before I leave for Colorado on the 23rd. So I'm going to start tomorrow.
Just a couple.
Yes, but the only reason I insisted was because the medical oncologist said, I asked him, if it was your father, what would you tell him to do? And he said, I'd tell him to start it right away.
Right. And let me say, if it was my father or my brother in this case, I would tell them I would encourage them not to wait. At the same time, be very careful with the prednisone in the sense that if you, I don't know if you have to wean on, but you certainly have to wean off of the prednisone. So even if when you come, and sometimes the doctors forget to mention it, sometimes even the very best doctors forget to mention it, because I've seen it happen. So just be aware that you cannot stop the prednisone cold turkey.
Yep. But it's a very low dose. It's 5 milligrams.
Doesn't matter. Is it are you on the 5 milligrams twice a day or 2.5 milligrams?
Once a day.
5 once a day.
Oh, that's interesting. Guys, Mr. Harrington and Mr. Correa, both of you are taking twice a day, no?
Yeah, mine is twice a day. It's 2.5 milligrams with the meal. I usually do it my breakfast and my lunch.
Okay, and Jim?
Yeah, Rick, I take 5 milligrams twice a day. I take it in the morning and I take it in the afternoon.
Right.
And whether I take it with food or not doesn't seem to matter much. One thing about prednisone that I find doesn't really do much to me and makes your joints feel better is that I don't take it at night. I find that it can affect your sleep a little bit. Other than that, but it's required by the docetaxel. You have to take 2 5s a day. Seems okay.
Right. Well,
and when I take
the question,
that's all.
Is, is it 2 5s or 2.5? Because some of the more recent studies have gotten by with 2.5. But what I've not heard of before, and I just would want to verify that, I would ask I'd ask Dan George when you see him whether he thinks it makes a difference with the prednisone, whether you take it once or twice a day.
That's a good question, Rick. I don't know.
I'll pose that question when I see him and give you feedback next time we're on the call.
Thanks. Thank you. I know that the trials, it was all twice a day in the trials. But some trials were at 5 twice a day, and some trials were at 2.5 twice a day. Yeah, go ahead.
Hey, Rick, I take 5 milligrams once a day. That's what the doctor prescribed.
Oh,
Scott Schroeder.
You're taking 5 once a day?
Correct.
Okay. Thank you, Scott. Okay, so there is at least one other person on 5 once a day. Okay. Well, just check. And I don't know what the difference is, but since you're going to Dan for a second opinion, he's a good guy to ask about the regime, the prednisone regime. The one thing I do know is if you do stop, be very careful to wean yourself off. Now, the other thing is that how long are you going to be in Colorado, Bear?
2 weeks. We're leaving on the 23rd. I think we're coming back on the 5th of May.
Okay, so then all I want to say is just be sure that whilst you're on the Zytiga, you're checking your PSA, because what you...
well, yes, the doctor said if he started it, he wanted to do blood tests right before he went for the trip.
Right. The only thing is that when you're still castrate sensitive as you are, then it's really hard to know whether you are responding to the Zytiga or you're not. Because most men in the past that have taken Zytiga have taken it after they became castrate resistant. So it was pretty easy to see if they weren't responding to Zytiga. The issue for you is we don't really know, because the Lupron's going to hopefully keep your PSA suppressed.
Well, I think the big test will be when he does a repeat of the scans 3 months after starting the.
Yes.
Right, and what you might want to consider is, and I don't know if it's covered. It's about to be covered, but you might want to consider the oncotype test for ARV7. The benefit being that if you are ARV7 positive, so you're not responding to the Zytiga, you're not going to waste time or money. If you don't respond if you're ARV7 positive, you're not going to respond to the Zytiga very well, nor are you going to respond to the enzalutamide, but you may well respond to apalutamide, the new one, Elida. And by doing this test whilst you're still castrate sensitive, you're going to find out. Now, I don't know what it's running you, but I do know that for some of the guys, even with the copay, it can be $2,000, $2,500 to $3,000 a month for the Zytiga. The test sticker price, well, there are 2 ways to do the test. You can either do it through Johns Hopkins, which is $1,000, or the sticker price, I just found out that the Oncotype DX test is $3,900, but I suspect the insurance is willing to pay a big chunk of that, because if you find that you're ARV7 positive, then they're not going to have to pay. Then you're not going to have to pay for your Zytiga. Does all of that make sense?
Yes, let me just share this with you. And I because I just spoke to the people today, it's ACS Pharmacy, some folks down in Florida, and they will be sending the Zytiga out to me. I have a grant for $7,500. I applied, and supposedly, and this is what my understanding is, they told me today, as of the first month, it will be $2,700, not my way, but the grant will cover it. And then in subsequent months, it goes down substantially. By the time you get to the 3rd or 4th month, and again, this is my understanding, They said it's going to be just several $100s. So they feel a $7,500 grant will cover me for an entire year. So right now, it does not have any financial impact.
Okay. I mean,
It would be very helpful to have some, it's hard to understand this test. Percent.
Rick, he's gone. I don't know.
Guys, it's simply this, AR-V7.
Okay, and if you're positive for this test, it means what?
Yeah.
It means it's unlikely that you're going to respond to either Zytiga or Xtandi.
Okay.
All right. Rick, could you send me that information just in a short email? Yes? He's not.
He disappeared.
He's muted now.
You're muted, Rick.
Yeah. The lips are moving, no voice. Yeah. If I could read lips, that'd be good. All right. I'll send them an email.
I guess you're up, Len, until Rick gets back online.
Okay, well, I don't know who else was on our list. Jake, do you have a record? Oh, wait, Rick is just sending. Yeah, he's just asking me to take over. But is there anyone who wanted to ask a question that we haven't gotten to yet? Nobody? Well, how about that? We've only got 8 minutes left. Rick, do you want to continue the call? Can anyone hear me, by the way?
The answer is yes to you, not Rick. Radio silence.
Okay, so you can hear me, but no one has anything further they want to discuss for tonight.
Tom Van Zandt or Ken Anderson or Paul Frieda or Jim Harrington?
Oh yeah, what about you, Jim?
Yeah, I'm not really. I'm just on chemo, and I get tired of docetaxel, and I've had 18 of these things in a row every 2 weeks, but I'm adjusting to it. Although sometimes the side effects seem to be more. But on balance, given what I hear from those on the call, some people really suffer from this stuff. And anyway, but on the good side of things, my PSA is staying steady at about 4.5 or so. So I guess you could say it works, but I'm puzzled why I have to stay on this stuff for so long.
Yeah, I haven't had that many treatments.
Well, I've asked that question to my doctor. Why? And my wife did too. He said, "You mean you're going to stay on this thing a year, 2 years, his life?" And I think the answer is that it works. So to a doctor, just keep doing what works. If I go off of it, my PSA goes up, or I have to go on carboplatin or something like that. That may be something I have to do, but. Yeah, it's kind of puzzling. But I did ask in the chemo ward. I'm in New Jersey at the Cancer Institute, and they said, no, it's not uncommon. There are people who just keep doing this, and every 2 weeks I go through it. Then I go through a nadir, and then I go back up, and it starts all over. But it does seem to work. Yeah. Other than that, no, I really have no comments.
Jim, what are the more troubling side effects that you're experiencing that you wish you could get off? Is it fatigue?
Well, I think actually the side effects of docetaxel as listed, I suffer from a few of them, but I do not get nausea. I do not vomit. The sore stomach and headaches, little headaches. But there's something else that worries me, and I brought this to my doctor's attention, is what are the long-term, and maybe somebody on the call may know, side effects of docetaxel. There are problems that can occur with your lungs, I believe. Anyway, they said, well, don't worry about it or something. But I am kind of concerned if I just keep taking this poison they put in my body every 2 weeks, what's going to happen down line? And I guess I really
don't know.
Have you
got any like second, third, and fourth opinions on this?
I did get an opinion. Yeah, I went to Sloan Memorial Sloan. I'm in New Jersey, and Rathkoff, and got her opinion, and she said go on carboplatin. So I don't know. I've not had a second opinion on this long-term approach, but my doctor, Dr. Stein, who left the Cancer Institute, he's now at Columbia Presbyterian, doing research on immunotherapy type things, which is what he wanted to do. I think just agrees just to keep going. But I must say, I'm beginning to wonder about it. I mean, but the only positive thing is my PSA does stay fairly constant with it. And I went off for 2 weeks. I said, let me just feel good for 2 weeks. The doggone PSA went up a little bit, up to 5 or something like that. So I don't know, maybe. And then I went right back on it. But I sure felt good for 2 weeks.
Hey, Jim, what's the dose that you're on?
For the docetaxel? Oh, boy, I don't know. I should know. I don't know. I think it's just a common dose. And I also get Neulasta every time. So it raises my white blood count. I've not had any sickness from it or from the fact that the Neulasta, if you know what that is, it's a little thing they put on your body and it pumps it in after 27 hours. But no, I mean, I actually am getting kind of used to it, I guess. I mean, but I always go through a nadir about 3 days into this thing. And I start feeling, as my doctor said, you're going to feel crappy for a day. Well, maybe it's a couple of days and then it starts over again. No, I don't know. I'm going to have to ask again, I guess. The doctor just says, just keep doing it. But